and welcome to Policy Exchange's Fringe event. I hope you're all having an enjoyable conference. My name is Robert Eade, and I lead health and social care work here at Policy Exchange. I know that Karin Smyth is coming from another event that finished at 10, so hopefully she'll be arriving momentarily. But because we've got we've got five excellent speakers, and we've just got just under an hour, I want to get straight into it. So the topic for today is trusted to deliver Labour's plan for health and care. Does the public buy into it? Are they winning the public around? And we've got a really excellent panel. So immediately to my left, we've got Dr. Charlotte Augst, who is Chief Executive of National Voices. To her left, we have Chris Smyth, who is a Whitehall editor of The Times. On my right-hand side, we've got Karin Pedley, who is Research Director in Public Affairs for Ipsos. And then on my far right, we've got Iain MacBeath, who is Honorary Treasurer for ADASS, and then is also Strategic Director for Health and Wellbeing for Bradford Council, and is Director of Integration for Bradford District Community NHS Trust. We're going to start with really punchy opening statements, 3 minutes. I will prod the speakers if they overrun, and then we're going to get into your questions because I want to take as many as possible. So without further ado, I'm going to ask Charlotte just to kick things off. Thank you, Charlotte.
Two lovely short women have just arrived. I wonder whether we could filter them forward a bit. Rubina and Julia, you can't see it. Oh, there you go. I can see your faces, which means you must be able to see mine. We had a little bit of a plan for health and social care yesterday, very much focused on workforce and long-term investment. And I think anybody who knows anything about health and care, quite set aside from party politics, would agree that long-term is now clearly the way to go. We've run out of sticking plasters well and truly, and we cannot really pretend to have a plan for health and social care if we don't start talking capital investment, long-term planning and long-term workforce planning. It's the only way to get value out of the money you put in, to do it long-term. But that, I think, in itself doesn't necessarily answer the credibility question in and of itself. If you think about what makes something credible, it's, on the one hand, do the people who know the facts think it might work? But on the other hand, it's also what can you get away with? And I think, you know, we heard about £350 million a week Brexit dividend at one point, and people felt that was credible. So credibility is a funny thing. And I think the effect of some of this parting of ways between fact-based, evidence-based credibility and credibility understood as what can I get away with, is that all of politics has lost credibility. And therefore, I think if Labour wants to achieve credibility for its health and social care plan, it needs to actually also address the general credibility of any kind of political announcements. And if you do make long-term political announcements, that's even more pressing, because people have experienced, I think, too often that you say in 10 years' time this will happen, and then, of course, it doesn't happen. And the money you might have put aside to make it happen gets raided for all the short-term stuff in the meantime. So my final thought would be, does Labour need to actually, as well as create credible, fact-based plans for health and social care, need to create mechanisms for reassurance that these plans will be seen through? If you think about the last time Labour invested big money in the NHS in the long term, which felt like we were reaching a similar point in terms of NHS underperformance, they created some mechanisms for accountability. NICE was created, predecessor organizations for the CQC were created, Commission for Public Involvement was created, and I wonder whether we do need something like this, not just here is what experts believe to work, but also here is how we're going to make sure, dear electorate, that this will actually happen. And I think that there needs to be some thinking around what that would look like, particularly for workforce plans.
Thank you, Charlotte. There obviously was some quite punchy announcements yesterday from Rachel Reeves on workforce, doubling the number of medical student places, for example. Does that feel deliverable? Because doubling it to 15,000 is obviously a huge increase.
I always think, if you think what the health and care system costs, I think we're now by near £150 billion. Creating a few more training places must be possible to find the money for that. And we're sending every year, we're sending the majority of people who want to become doctors and nurses away and say to them, no, you can't. So I just find it hard to believe that that couldn't be achieved.
Great, thank you. Chris?
Yeah, so I think I'm here to sort of talk about where the politics meets the policy on this, and obviously the traditional divide is that Labour used the NHS to rally their base. One of the few things that Tony Blair and Jeremy Corbyn had in common, both had this sort of 24 hours to save the NHS election pitch to get out the base. On the other side, the Conservatives just try and neutralise it as an issue and make it go away. David Cameron was initially very successful in doing that with his, my priorities are 3 letters NHS. And you can see the same instinct in Liz Truss sending Therese Coffey, one of her most trusted friend, in to sort it out, as she calls it. Although it was quite striking, given the 3 priorities that the government says it has, and how bold it was on energy and the economy, how timid and small bore its announcements were on the NHS. Although given what's happened in the last few days, perhaps we might be grateful for that. But the thing is, actually, on policy, there isn't really a huge amount of disagreement between the parties. Ever since the Lansley reforms for the last decade, there's been what Simon Stevens used to call a latent consensus between the parties. I think, in fact, the creation of NHS in England has allowed that to come out a lot more. Everyone agrees that we need more staff. Everyone agrees that we need more prevention. We need to shift more care out of hospitals upstream. Everyone we need to fix social care. I think, perhaps from a policy point of view, the more interesting question is why for a decade we just haven't been able to implement this, and what that says about how we're actually trying to drive change in the NHS. But that is a bigger question. So where are Labour then on this? And you saw yesterday very clearly how they are trying to use the NHS as political positioning. Rachel Reeves saying we would bring back the 45p rate of tax and use it to fund training places, which is a gift to them. They were clearly going to announce that training places anyway, but by saying, oh, we'll fund it with this 45p rate, they can say Tory tax cuts for the rich versus more staff for the NHS, which even some Tory ministers are thinking, I don't really like the sound of that. So that is a useful political framing for them. Yet at the same time, you've got Wes Streeting saying very clearly, we're not just going to pour money into the NHS. It's unsustainable to just raise the budget of a 20th century system. We do need reform. And again, whatever its virtues of this as policy, the politics of this are quite clear. Given where the government is going on the economy, the Labour pitch at the next election is going to be, you can trust us, we're the sensible ones, we're going to be sound, responsible with government, and they can pitch that on the NHS as well, saying we're not just going to throw your money at it, we do need to fix its problems. So where is this going to go into the next few years, into the next election politically? I don't think anyone expects that whatever the government does in the next few years is going to fix these problems. They might stop it getting significantly worse, but no one really expects to go into the next year with the NHS in a much better place than it was, and people saying, they've got a handle on that. So I think it's interesting where the political debate goes there. A lot of people in NHS England are very worried that the temptation for the Conservatives is going to be, you've heard the talk about, we're the patient champions, we're on your side, we'll drive it up. Well, the prelude to that is, we're on your side, the bureaucracy has failed, it's their fault, only the Conservatives can be trusted to stand up for patients against the health bob, and that will be the pitch into the next election. And you are already seeing, after years in which the NHS was protected by Brexit, because the Conservative right won that with a pledge to fund the NHS, you are now already starting to hear those voices on the right of the party saying it's not working, let's go to a social insurance model. And, again, that is potentially a good position for Labour to be in politically, to go into the NHS saying we're the sensible grown-up ones, we know it's got problems, but we're going to fix it, but we're not going to do it through radical, scary change at a time when, volatility is a bit terrifying and stability is what people might want. But I think in the longer term, there is going to be it is going to be difficult because the demographics are against us for the next 10 years, at least, as the baby boomers get old. When Tony Blair came in, he did have a growing economy, and Liz Truss has got a point that it is much easier to fix these things if the economy is growing, and he was able to basically double the NHS budget with a relatively restrained 1p rise in national insurance, and whoever wins the next election, they're not going to be able to do that. So Labour is at some point going to have to answer some difficult and more fundamental questions. They are going to need more spending, but at what pace are they going to increase it, and where are they going to prioritise it when all these competing demands are clearly going to be difficult to resist after the last decade?
Great, thank you very much, Chris. Iain, it'd be great to hear the perspectives from social care, because we've been quite focused on the NHS so far.
Absolutely. So ADASS is the Association of Adult Social Services Directors. So that's why I'm here today. But I'm a jobbing director in Bradford, which has got its issues around the way that social care's funded. I just want to start off by saying what's going well, because hundreds of thousands of people do receive social care every day, and hundreds of thousands of people work in social care, and they do a brilliant job, and people are generally satisfied with their social care. So sometimes we talk about the crisis, and it must feel terrible for them to think, crikey, I'm doing this every day, is that me? And they're doing a brilliant job, and people are generally satisfied. However, there are issues in social care. So we know, as at today, 300,000 people are waiting for some kind of assessment in adult social care because we're short of social workers, occupational therapists. We know we've got 165,000 vacancies, so a lot of people are waiting for their social care because we don't have the capacity to pick that up. Turnover is at around 40%, and if you ask people what they want, the most important thing to them is the same person. They want the same care worker to do their most intimate care, and yet turnover is 40%, and so very few people receive that year on year. And as for the care market, we know today 170,000 hours a week were short to get people out of hospital, people waiting in the community. Those home care hours that people need to meet their eligible needs, we can't deliver because we don't have capacity. We've got all those vacancies, and add on top of that inflation. If you're a home carer driving a car around on your visits, petrol and diesel, if you're running a care home, you can't turn the temperature down. All those things are massively impacting businesses, to add to workforce, to add to the end of COVID, and just that general fragility. So what would a radical agenda look like? I think number one, we've got to think about how we stabilise this sector. It can't fail. Hundreds of thousands of people rely on it, their lives rely on it. So we've got to stabilise the sector and resolve some of those financial and workforce issues. I think number two is we need to have an honest conversation about what social care's for and who it's for. And we probably need to ask people, because it's becoming an emergency service, and actually it can be so much more than that if we design it properly. And it's got to be more about prevention and early intervention. And most councils now are delivering the majority of their budget and their social care at the very heavy end, the care home placements, the heavy home care placements. And we want to invest up front on prevention, but the money, the resources don't allow us to do it. So my radical agenda would be a public conversation. People need to know what social care is, not only at the point when they need it, but everyone should know what it's all about. All of us can be affected by it at any point. What does locally integrated care look like? I say that wearing two hats. I'm a director for the NHS as well as working for Bradford Council. Loads of opportunities to join up health and social care, not to merge them, not to make social care part of the NHS, but just make sure our services are joined and seamless to people. We need investments in housing. We need a fully funded workforce strategy. Where does technology fit into all of this? What about support for carers? So a big agenda, but we've got to ask what's it for and fully fund that workforce strategy.
Iain, I just want to pick up on one thing you said. You talked about not having a merger with the NHS. Yesterday, I believe, at another Fringe event, Wes Streeting said he'd be interested in bringing all social care workers onto Agenda for Change style terms. What's your assessment of that?
I'd be delighted. So ADASS' stated policy is that all care workers should earn Agenda for Change Band 3. That's a healthcare assistant. That's a minimum that social care workforce should earn. So if the government give us the money as commissioners in councils to pass on to providers, we wouldn't have all this huge turnover of workforce from social care into the NHS, never the other way around. We would dampen down some of those problems that we've got at the moment, so I welcome it.
Great, thank you very much. Karin, it'd be good to hear your assessment of kind of where the public is at, and particularly sort of drilling down into their appetite for greater investment and some of the thorny issues that Chris alluded to.
Thank you. So a couple of remarks on the NHS and social care, because I think in many ways, public opinion does tend to separate the two to some extent. So 77% of the public tell us that the NHS is crucial to British society and we should do everything we can to maintain it. So, and this has been consistent over the past 20 years. So it's something that's clearly of importance to the public. And yet, recently, 7 in 10 have told us that they think Boris Johnson's government did a bad job at improving the NHS. Some of the reasons for that, people are concerned about waiting times. 3/4 of the public think that they're too long, unacceptably so. And people are also concerned about staffing levels, but also staffing workloads within the NHS. And when you put all that together, what we find is that the Labour Party has a 22-point lead over the Conservatives in which party is most trusted to improve the NHS in the future. So clearly there is a sort of political advantage to this from Labour, not that that's the only the concern that people have. On adult social care itself, I think I would describe people as concerned but also somewhat confused as well. When we ask people their priorities for adult social care, but what we find is people say they want it to be affordable, first and foremost, but also they want sort of qualified staff that have the time to care, and also that those services are personalised to people. And there's strong levels of concern about the delivery aspect on some of those, particularly not so much the quality of care provided, but that the staff have the time to spend providing that care, and also the affordability question too. And on that latter point, I would say that there is this confusion. I think there is a latent assumption for people that don't necessarily have to deal with the situation because they're younger or they don't have family members that sort of need care at the moment, that this is something that's part of the NHS. And there are sort of around sort of 38% of the public that think social care is free at the point of need. 3 in 10 think that the NHS provides the majority of those services. And then finally, again, on this confusion point, you do find that this is something that people don't necessarily engage with until they need to, either because they reach a certain age where they start thinking about it for themselves, or because a family member experiences the need for those services. So we find that a minority, 40% of the public, tell us that they've thought about preparing for what they might need financially for health and social care in the future, but even fewer have actually done any meaningful preparation. So I think these issues are very important to people. Yes, of course, the cost of living crisis is dominating the agenda at the moment, but the NHS and healthcare is never far away. And I just think that when we talk about joined up services, bringing the public on that journey so that they sort of are with you in policy terms is important, because actually the public are split on whether they should have any responsibility for saving for social care in the first place.
Great, thank you. That's a really punchy summary. I'm going to throw out questions in the audience in a moment. I have been texted to say that Karin is on her way across, so hopefully we'll be able to join us. But perhaps just to start, let's get into some of the solutions and Labour's offer. One of the longer term things that the Shadow Health team have announced is this major report review looking into establishing a national care service on similar terms to the NHS. So it would be good to get the panelists' thoughts on, is that part of the answer? Maybe I'll start with Charlotte and then go to Chris and we'll follow the order.
I have to say, I'm finding it a little bit difficult to understand what's meant by that. Wes said yesterday at an event that we both spoke at that it's not about nationalising the sector or one-size-fits-all, top-down reorganisation, but that it's about national standards, what people can expect, and also in terms of pay and conditions maybe for care staff. I mean, in terms of what people should be able to expect, we have that already. You know, we have NICE. So I just find it a little bit hard to understand what that would add. And it's not, councils don't want to break these standards. They just can't get in there early enough, as we've just heard from Iain. They become a hyper-acute service in a way. So I struggle a little bit to understand where that is going. Yesterday, where I said something about big chains running care homes, private equity taking money out. I mean, maybe that's where that is going, but I don't see an appetite to kind of roll it all into one big homogeneous blob. So yeah, I think more detail for me needs to emerge, really.
Chris?
Yeah, I mean, on the policy of it, I think that's right. It's not clear what it means, and it's not clear that it is, nationalising it is the solution to the problem. I suppose the political advantage is to tackle some of the thing that Kieran was talking about, that people not knowing what social care is, not prioritising it. And if you have the same, branding, to be frank, you put that up people's consciousness and they start to recognise it. You know, when I first started writing about health more than a decade ago, I would never write the phrase social care because I think people won't know what it is. That has changed. People do know what it is now. It is up the agenda. It's, you know, in the name of the department in a more obvious way. So it is getting there. But I still think there is a political challenge in terms of people just not wanting to think about it. A, because it's really depressing to think about getting old, and if people just, you know, put their fingers in their ears. There is also the sense that most people don't have significant care needs, and so most people just think, well, I'll probably be one of the lucky ones. Most of them are right, but those who are not are really in difficulties. So, and then there's finally the big problem, the political difficulty is, you know, you have to pay for social care. You don't have to pay for the NHS. If you bring them together, you have to and make it free. Well, that's very expensive. If you don't, you have these continued rows about pooling budgets. And that's before you get into the issue that you alluded to about where is the responsibility lie. I mean, it's pretty clear. If you've got a broken leg or you've got cancer, well, that's the NHS's job. With social care, it's much fuzzier. You know, if you need help with your shopping, is that all the state's job? Where's your family responsibility? These are areas that politicians really don't want to wade into because they quickly get quite controversial.
Great. Iain.
I think Wes clarified that he didn't mean he was going to nationalise, as in bring all the services back in under the state. It was more about setting standards and so on. And quite a lot of that is part of the current government's agenda. So we've already got national performance indicators. We've got the Care Act 2014, which is our standard piece of legislation that arguably we've never really had the resource to implement. And in the last piece of health legislation, they announced the re-inspection of councils by the Care Quality Commission. It's the only part of the health and social care system that's not currently inspected. So that's become part of government policy now. And I was part of seeing some of the forthcoming assurance inspection framework. So I saw what kind of things they're going to test and what kind of evidence they're going to collect when they start inspecting 151 councils like Ofsted do for children. So a lot of those building blocks of what a national care service would be are already in place. The more interesting bit for me would be to look at what we're spending individually as those 151 councils, because since the demise of the Audit Commission, we've lost track of what councils are spending, and the way that social care has been funded, particularly in the last 4 or 5 years through council tax, has been a very aggressive way to fund the system. Social care needs are higher in areas of deprivation like Bradford. My previous authority 2 years ago was Hertfordshire, which was completely different to Bradford, and 2% of council tax in Hertfordshire raises about £22 million, and 2% of council tax in Bradford, which is half the size, raises £6 million. But there's still a chasm of difference there, isn't there, between Hertfordshire, where health inequalities are smaller, and Bradford, where they're huge. So we've been funding it in the wrong way, and the chickens will come home to roost when we start comparing and working out why that is. And the answer is councils have been given access to funding in different ways that haven't met the local needs.
And I know, just obviously we are here at Labour Party conference, but the current Prime Minister certainly raised eyebrows in the sector when she suggested that she would move 13 billion from the NHS's budget across into social care. And I think the announcement last week, they said that the £500 million was a down payment on further investment in social care. So do you feel like the conversation around funding, there is a sort of new consensus that it does need to start to get more money?
Well, I do. I wonder what they're going to spend it on, though, because the current government's policy is about charging, and it's about turning off a tap, which is people who've got assets and private pensions and savings not contributing as much to social care as they do today, and the government providing more. So actually, all of that 13 billion could be taken up with that policy shift, and there wouldn't be a penny piece for an extra hour of home care or an extra 10 pence on a salary of a care worker's wages. So at the moment, I fear all of that 13 billion will be required to make that charging shift. None of it would add to the workforce or the capacity issues that we've got.
Karin.
I think the devil's in the detail with a lot of these policy decisions, because I mean ultimately I talked about the difference in public perceptions between the NHS and adult social care earlier. I think it's a very clear distinction between, with the NHS, people expect it to be accessible when they need it, and they like the idea that it's there. And I suppose with adult social care, that to a lot of people, there's the same assumption. unless they know different through family or their own personal needs. So we could talk about national care services and all the rest of it, and they sound good in terms of branding, but I think what the public will want to see is what that means in practice for them. Does that mean it's going to be free at the point of need for everybody? If not, where does that line drawn? What does that mean in terms of the frequency and sort of the general sort of access and quality of care that you get? So I think really, in public opinion terms, given that the public are so sort of I use the word confused about what the actual sort of agenda is at the moment, I think more clarity on that would be what the public wants in the future.
I'm keen to get questions, so if you could please raise your hands. I can see you already got a few hands, which is fantastic. Do we have a microphone? Is there a roving mic, or do people just shout? Claire. Great. So I'll go for the lady at the front there, then we'll go for the lady at the back, and then we've got another lady in the second row here. And if you could introduce yourself and make it a short question, thank you.
Hi, I'm Vivian Clark from Wirral South. I'm a retired GP after 30 years as a GP. I wondered if you had thought about retention. I'm very impressed about the plans for expanding the medical workforce. But there's a big problem with morale, especially amongst the junior doctors. My son is a junior doctor, and I'm horrified by how he's treated. These are skilled people, and they don't feel valued at all. They do long hours, they have to cover loads of rota gaps, and they feel that they're treated as cogs in a machine. There's nowhere for them to rest, even when they're doing nights. There's nowhere to even sit down. And there's no hot food. There's just no care of them at all. And
thanks. Just so we can get the so a point on retention and the quality of terms. Thank you so much. We'll go just to the next one. Maybe if we just take the one down here, Claire, just for ease, and then we'll come back to you. Just so we'll take all three together.
Hi, my name's Hannah from the Samaritans. I'd be interested to hear from you what you think Labour should be announcing when it comes to mental health and suicide prevention specifically.
Great, thank you. And then just the last question at the back, and then we'll throw them back to the panel.
Hi, Sarah Woolnow, Asthma and Lung UK. I wanted to ask about prevention. It's picking up on something Chris said, that all the parties sort of understand now the challenge of prevention and sort of stemming demand on the NHS, but you don't have to scratch much beneath the surface for that to, I suppose, fall apart or be tested, i.e. people politically don't necessarily want to implement the change that's evidence-based that we know will make the difference around tobacco control or obesity or air quality. So I'm interested in what the panel think might happen over the next few years, and from Karin's perspective, the polling on this would be interesting.
Great. So retention of the workforce, what's the offer around mental health, and then prevention, the politics and the reality of getting evidence-based policies through. Chris, maybe if we start with you, and don't feel you have to respond to all three.
Well, I mean, just on the last point, I mean, it is harder when finance is so constrained, because it is tempting if you're a politician to think, well, I could put money in here and it will lead to a better outcome in 5 years, or I could put money in here and I will see a sort of immediate thing that I can, boast about at the next election. So that is just a tension that's very hard to get away from in the kind of taxpayer-funded, politically run healthcare system that we have. Wes Streeting has said he's going to make some announcement tomorrow on moving resources further upstream. So it is something that you can see certainly Labour trying to prioritise, and I think the political incentives are probably better for Labour to do it coming into an election if they can say, well, we're going to start again with a new government fixing the mess that the last lot left us. It is easier for them to say this is going to take some time and build for the longer term than it is with the current government who really need to see results in the next 18 months.
I'm actually going to start and go with Iain and then work back and then finish with Charlotte.
I'd just go to the mental health point. I mean, there's loads we can do around prevention and suicide prevention for mental health, and social care's got a big part to play in that too. In Bradford, we're testing all kinds of different preventative methods, including online, which is massively popular with young people, and we're really targeting that at some of our different communities in Bradford who might not ordinarily come forward and present themselves to mental health service or even to their GP to talk about it. So there's such a wide range of services. We're trying to get involved in some research to be able to pass on some of the good practice that we're taking forward and share that, so that not everyone's got to follow that track. On prevention, I'd make a similar point. short-termism is really expensive. If I look back at the monies, the short-term monies that have been provided even over the last 5 or 6 years, and if I'd been told how much money I was going to get in 6 years right at the start, I'd have done something completely different and invested in completely different services, hopefully with more success than I have by announcing £500 million or £1 billion as sticking plasters, which sounds like huge amounts of money, but it's such a big system. When you boil it down to what you get locally, it's not an awful lot. So, yeah, my message would be short-termism is really expensive.
Just to deal with a couple of those points very briefly, I think on retention of staff, as I mentioned, in adult social care in particular, but also in the NHS, people do recognise the importance of that staffing levels, but also the ability to have consistency in who provides that social care to either yourself or your loved ones. I think there is increased sort of recognition amongst the public that preventative healthcare is necessary and important, whether you're talking about issues like mental health, but also physical health, like your healthy eating or relationship with smoking or alcohol or whatever it might be. So there is definitely sort of increased sort of appetite for some of that. I guess it's an age-old battle between some people not liking being told what to do and how you sort of encourage or nudge positive behaviour. But I think consistent education programmes around a lot of those issues are working and are helpful, but obviously need to be continued.
Can I just pick up on one point, on the one around retention? There is obviously, following the pay review body's decision, there is a possible risk of industrial action, strike action later this year. Where's the public sentiment on things like that? Are they in the corner of NHS doctors and nurses, or do you think they would end up siding with the government?
I think so. When you ask about trust in different types of professions, NHS doctors and nurses come somewhere very near the top. In fact, nurses are at the top. So I think the government ought to be careful about picking fights or being seen to pick fights with healthcare workers, particularly in the aftermath of COVID, when that sector was very, very popular. I mean, in short, if we can distill attitudes to strikes down to a sentence, it's a difficult thing to do. But I think, like broadly speaking, the public are supportive of the right to strike, and they recognise that the importance of the role trade unions play in public life. And actually, when you give people the choice between protecting the right to strike or making it more difficult, people tend to side with protecting the right to strike. It's not universal, but people are more likely to say that than they want to make it more difficult. Of course, the real challenge comes when the disruption comes, and God bless the public. They like the idea of strikes, but don't like necessarily the disruption that they bring when they happen. So I think it depends on the level of disruption and what that means for people's services. But I think when you look at strikes, it does depend a little bit on what the profession is that's doing the striking. And when it's healthcare professionals, there's much more likely to be public sympathy there than perhaps some others.
Karin, hello.
Hello, I'm terribly sorry. I won't bore you with a catalogue of disasters.
That's okay. One minor thing is the microphone. Make sure it's sort of close enough to you. Okay. What I'm going to do, I'll let Charlotte just respond to the 3 questions that we had, which were covering prevention, mental health, and then sort of retention of the workforce. And then it'd be great to bring you in for some thoughts.
Yeah, I'm going to try to answer the question on prevention and mental health possibly together. So I think sometimes the way we talk about prevention kind of juxtaposes unhelpfully that you can either spend the money on the NHS or on prevention. And I wonder whether it's worth trying out, and that's what I would say to the health team, in terms of thinking through how to land these arguments, that we cannot actually run a health system free at the point of views if we do not show an interest in how people are forced to live their lives. And it's this winter of all winters, I think, so very obvious that you cannot actually deal with the need that you create in a free at the point of use health system if you don't also show an interest as to whether people can heat their flats and feed their kids and have a job and get their kids into school. So you can only have the one with the other. So I think people's love for the NHS needs to be translated into an understanding that we need to show an interest in health in all policies. And that clearly then also applies to mental health, because I think there, of all areas of healthcare, there's no chance in hell that we can respond to the extraordinary levels of distress through the medical model. Clearly we need the medical model for some people and in some situations, but we need to get, again, serious about the impact the cost of living crisis has on people, the impact debt has on people, the impact bad work has on people, the impact bad housing has on people. And I think there is a way of telling these stories that feel intuitively right to people and that don't get us into nanny state arguments, finger wagging, and a sort of unhelpful, you can either spend it on prevention or the NHS, because essentially we need to do both, and we need to do both well.
Obviously, Wes raised a few eyebrows yesterday. Just one brief follow-up. When he said that he would not reintroduce the buy one, get one free ban, and he sort of cited the cost of living crisis as one of his political motivations, I guess, behind that, given the sort of wider system pressures as he viewed it. What's your reaction to that?
I think that is regrettable, but I also think we need to get much more serious on the structural drivers of health inequalities and ill health, and really drop some of our obsession with the individual decisions people make. And the buy one, get one free is kind of straddles both to an extent, but it still tries to target individual decisions people make and do so through cost. And I think that is obviously a difficult sell right now. There's a lot more that could be done. If you just look at how, the housing standards in this country, the sick pay people get, how people are treated in 0-hour contracts, there's a lot you could do that doesn't feel like you're hectoring people, but you actually help strengthen their health.
Karin, I'd love to bring you in now. I know we've drifted the conversation onto all areas of health and care, but feel free to speak to your brief, but give us some tasters maybe for Wes's speech tomorrow as well.
Thank you. It's always great to be nearer to another Smyth with a Y as well. That doesn't happen very often. So, Karin Smyth, I'm the Labour MP for Bristol South, and I have spent most of my career working in the health service before becoming an MP. And just to stick slightly to topic, the reason I joined the health service back in the late 80s is I was motivated by the Black Report. Anybody old enough in the audience to know what I'm now talking about? So the Black Report in Public Health released after the Tory government came in, because it was suppressed in the 1980s, actually, because it essentially, paraphrase, told us that after then 30-odd years of the welfare state, that health inequalities were still a major problem, and that poorer people did worse out of the system. And that seemed to me a real challenge. That's what drove me joining the health service, and actually has driven my politics in the intervening years, updated recently by Marmot, and I frankly see no reason to have any more evidence than both of those reports and lessons over time, and we should all look back to that to understand that inequalities and health inequalities are a major burden on the economy. They're bad for people, a major burden on the economy, and we should always be looking at prevention across all policies. I do completely agree. And that is also true in social care, which is my brief. They're looking at the numbers, but for example, falls in the Bristol area cost, upwards of around 20,000 bed days in the year is what they're trying to think of at the moment. Now, I'm horrified that we've got to a situation that our falls prevention services are not really top notch, because I was working on some of these 15 years ago and people were working on them before. Falls are such a tremendous indicator, particularly for older people and particularly for older women, of health need and demand, and actually quite a simple problem to start supporting with understanding what happens to your brain, your balance, and as well as aids and adaptations to sort out. So I think you can find the need for prevention across all policies, I agree. And just sort of random thoughts. I do think the pandemic, again, has offered opportunities for people to think about health and well-being in a different way. When everyone discovered that if they lived in the same street, that was actually quite a nice green space, only 100 yards in a different direction than they usually go to. As we wandered around our neighbourhoods, we started to understand much more about what worked and what didn't work in terms of public space. We used the space differently. We challenged ourselves to get out a bit more and to do that regular walk for people who could do that. And then how many of us have actually forgotten to do that regular walk or to find that hour again? And I think we don't want to lose some of that stuff. We all want to forget about the pandemic, but there are ways of thinking about public health and well-being for ourselves, which is a good thing, as well as in terms of not using public resource through just the health and care system. And I'm so sorry to miss opening comments, but I've always been a fan. I was a supporter of the move of public health responsibility into local government. I think that that was possibly the only good thing that came out of Andrew Lansdowne's head 12 years ago. Just really criminal by the coalition government then to start taking money out of it. Really, really short-sighted. And of course, it's never really recovered. So all those people who do argue against a localised system for health and care, of which I'm not one, I'm very much a Morrison, not a Bevan, because people will be bored of hearing me say, you know, the opportunity to actually build in good public health throughout our localities, in health and care, but also in our planning and our design and our housing, is almost lost because of the severe cuts to those budgets. And it's politically lost. So it is great to have a debate here at conference on public health more, because I think it's lost some of that public salience, really, and political salience as such an important driver of what it should be, of both not only the economy, but of the health and care system.
I want to just press you on one thing, because we were speculating as a panel about this National Care Service that Wes has obviously commissioned the Fabians to do a piece of work looking into it. It seems like he's potentially rode back from the idea that this would be bringing everything under the state, and it would be kind of common standards. How's the sort of vision panning out? How do you see this National Care Service sitting?
I don't think there is any rowing back. The principles around a national system would largely be around pay, terms and conditions and standards, and with a delivery that is local. And of course that will, I mean, the current, it's a long topic, but obviously particularly around social care, so much of provision is private. And of course, you know, the social care system is in such a poor state and is not getting better anytime soon, that would be at least a 2-terms ambition, really. We're talking about a long-term ambition. You know, the Conservative tenure was a 10-year plan, and it's not a plan, as we've heard from the Select Committee this summer. There is no fix currently. It is not a plan. And I think we'll hear more from the government about that in coming weeks. We started to have some hints last week. So for us, yeah, terms and conditions for both people giving and receiving care is absolutely critical. The workforce is critical, and that is you know, people need to know what those conditions are. And I think for people receiving care, they need to know that the quality standards are the same wherever you are. That is the dilemma of the health service and the Bevan and Morrison models, and that would obviously involve a range of providers.
I'm keen to get some more questions from the audience. If you raise your hands, great to see so many hands. So if we start, we'll take one question at the front, then we'll take one question with the lady with glasses on her head, and then we'll take the gentleman at the back as well.
Hi, Declan Mullany from Livy. We're a digital primary care provider. The Health Secretary set an expectation that everyone should get a GP appointment within 2 weeks if they want one. Given I think Karin touched on this, the frustration in the general public around accessing primary care, do you think we need to have an updated offer or conversation with the public around how and when they access primary care?
Great, and then we'll just go to the lady over there.
So my name's Jenny Holmes. I'm a psychiatrist and I work with NHS Practitioner Health. So my caseload are NHS professionals who are burnt out, poor mental health and leaving the profession. I'm disappointed at the level of this conversation because it's funding. I'm really disappointed Keir Starmer has rode back on that 1% national insurance increase. I realise there's cost of living, but my understanding that was quite widely accepted by the public as a good thing. And to me, that was the obvious, you know, forerunner to progressive taxation, health and social care assurance, which could have been sold by that.
Could I just press you for a question, please?
That is the question, funding. Okay.
So how are we going to pay for it? Well, that is an excellent question to put to Karin, so thank you.
Hi, my name's Pierce and I'm here with the Patchwork Foundation, which is a charity getting young people involved in politics. My question is regarding the role of the voluntary sector within health and social care, particularly when you're talking about the state kind of expanding its social care operations and taking on more responsibilities from probably voluntary sector works. There's quite a few communities within the UK which don't necessarily trust a sort of medicalised model and a state getting involved in issues, for example, whether it's people getting tested for HIV, whether it's people seeking out mental health support if they've been through domestic abuse or hate crimes. There's lots of communities which don't necessarily trust the state in this regard. And so what can be done if we agree that a sort of more expansive state role in social care is necessary? What can be done to make sure that we're bringing communities with us and that it doesn't just exacerbate social inequalities?
Thanks, Piers. I will take one more question because we probably don't have any time for any further on. So the lady at the back there.
Hi, my name is Augst. I'm a policy manager at the Chartered Institute for IT. I did notice kind of an absence of the role of digital healthcare and tech and digital in health, and I was wondering why that is. Is that because you don't believe that digital and tech has a role in revolutionising the health service, or is it not a priority of the Labour Party? Why is that? And if it was a mistake, what is your plan for digital health?
Great. Okay, so just to recap then, GP access, do we need to have a different conversation with the public? How are we going to pay for all of these policies that Labour is announcing on health and social care? What's the role of the voluntary sector? And is there a sort of transformation off around digital and technology? Karin, maybe if I start with you and then we'll go down the line.
Okay. Should we share this microphone?
Yeah.
Is that probably easier? I mean, I'm always in favour of conversation with the public. I think the public are, I think someone said earlier, trust the public in terms of what a good quality health and care service looks and feels like, and then what that costs. And I think, I mean, one of the reasons I'm very much a supporter of localised conversations, and that does include community groups and organisations that are trusted in those communities to pick up that question. And I think people are reasonable in that. One of my last jobs in the health service was 12 years ago trying to persuade GP practices to use the telephone and this whole new thing called the internet. And we had to try and introduce a dermatology service that used this thing that you could take photographs of and then send them through another thing to a hospital that someone else could look like. And it was like sometimes getting people to go to the moon. And so I find personally the debate around online access telephones, you know, I do look back a little bit and think, oh, if only we'd got to 50% of people using the telephone and so on in some practices. So that's my way of saying it's hard to get some of those changes. But if you talk to people actually and say, no, actually we will go with this. People liked it. We will go with this. If we can get an answer on the telephone, that will be good. Thank you, rather than the aspiration of 2 weeks wait. So those conversations with people both nationally and locally, I think, do allow you to change service models that are better uses of resources and the very, very valuable clinical time that we have, because GP time is very, very precious resource, because they are highly skilled individuals, they are highly trained in this country, and we do need to make the best of them in different practice models, and we've got examples of that throughout the country. And I think people will respond to that conversation. Shall I just keep trying to avoid the paying question?
Seems to be an enduring theme from this fringe, actually.
Well, I will come to it. I do think that to answer the question, particularly around models of care, one of the things we commissioned was, you know, people like the Brook Advisory Centre around contraception and things for young people. That would absolutely remain part of our consideration, that you have groups to respond to, particularly public health, you know, the issues that come through, like HIV, for example, of people that are peers that understand those conversations and absolutely support that public health model. And of course, look, good public health does yield, and benefits the economy, does yield wider benefits into the economy, and paying the women in my community a decent wage to work in the social care sector that they will then spend in the local economy. It is the quickest way to level up our economies across our country, is to pay the women in the social care workforce and give them the terms and conditions and holidays and sick pay that they deserve and that the rest of us expect, is the best way to level up local economies. So we do need to look in the round about how social care particularly is an infrastructure issue that supports the wider economy when people start, when you start looking at the money. And absolutely, Rachel is somebody who does understand that both social care and childcare are infrastructure issues. just like roads, and do benefit that wider economy.
Obviously that's a longer term payback though in dividend, but in the short term, is it borrowing or is it increasing taxes that is going to pay for some of this stuff?
And and I think everybody knows the answer to this question, that obviously when the election is called, we will lay out in detail with the OBR, which is not what the current government is obviously doing, any kind of transparency about how we will fund, how we will prioritise those commitments in a manifesto and how they will be funded.
Chris.
Oh, just to pick up on the point about the digital infrastructure, which I think goes to what Karin was saying, and also the point earlier about actually a lot of this is not about policy, it's about implementation, and politically it's always much more appealing to announce a shiny new policy than to think about why it is that the ones we've been announcing for the last 10 years are not making more of the difference. And that ranges from the sort of high level thing of Treasury not wanting to sign off a one-off investment in digital infrastructure because they don't trust the Department of Health to do it, to the everyday mundane problem of GPs are basically running a small business. They're very busy. They're being told absorb loads of pharmacists, do all these other things. It's just very difficult for them to get the time and the bandwidth to think, what I want to look like in 10 years. Let's talk about suddenly become experts in digital procurement. And I think helping from the government, sort of helping them with those every day in the same way that sounds like you were doing 15 years ago, helping them make those decisions more easily so that they can be implemented without huge amounts of faff and terror on the ground is a sort of more thing that we need to think about, perhaps more than the headline policies which get attention but don't actually solve these problems.
I'm just going to ask, because our next fringe is starting at 1:15, for the remaining three speakers, if you can keep it sort of 1 to 2 minutes, and then we'll wrap it up. Max.
Right. I'm going to pick up the question on access and also the role of the VCSE. So I do think, this 2-week wait thing is really baffling. I just think it's a sort of solution in search of a problem. The health problem that can wait 2 weeks but not 4 needs to be invented yet, I think. And the health problem that can't wait 2 weeks probably also can't wait 1 week. So I just think it's a very, very odd target. I think we have thankfully though moved on from this wretched, is it face-to-face or digital conversation which blighted access to primary care in particular for the last 12 months or so. I think the frustration people have with the digital offer is not necessarily that there aren't problems that are really very easily and well solved by a phone call or a remote consultation. A lot of people are using it and a lot of people are very happy to use it. The problem, I think, is that people want more than that sometimes, and they want two things. They want a recognition that they're in distress, and they also want someone to shoulder the burden of making the fragmented transactional health system work for them. And I think that takes me to the question around partnership with the VCSE. That is where the VCSE has all its strengths. We can do that. We can do the hand on the back of your hand, and we do that really well, and you do not necessarily need to be a fully trained medical professional to do that. And we can also help with the coordination of the unwieldy health and care system on your behalf and argue your corner. And we've got Juliet here from the Stroke Association and Brian from Rethink, and they can talk, for hours about the brilliant models that they're implementing locally to make a difference in people's lives. And small charities are doing the same. Positively UK are embedding care coordinators in HIV clinics, and a small member of ours, Midday, work in Northwest London with women who've experienced genital cutting, and they advocate for them in obstetric services. This is the work of the VCSE, and the health system needs its head examining if it doesn't really buy this wholesale.
The person who's chairing the next event just did a cutthroat sign at me, so we're going to have to be... So for my future work relationships, we're going to have to be very quick. Thank you, so Karin.
No, just very briefly on the funding question that the lady mentioned down here. It is true that people recognise that health services need more money, and that it will often poll well if you ask people about modest increases in taxation to pay for that. The problem Labour have got is obviously putting that in the wider context going into the next general election, where there's going to be a big argument on taxation and the cost of living and what that whole package looks like, because obviously the Conservatives are going to want to say, Labour will raise your taxes, we'll cut them, we'll reduce your cost of living, etc. So whereas the public do recognise the significance of this issue and welcome more money for it, even if it is increasing taxes, you've got to put it in that wider context in a general election campaign.
And I suppose just a part of a summary, really, thinking about all the 4 points raised. If you've got a good integrated care system locally that includes the voluntary sector as key partners that are sitting around the top table, then you can talk about digital, you can talk about helping primary care with people's different needs and making sure they're spending their time optimally, and you can have good funding discussions. So Wes did say he doesn't want a top-down reorganisation, so let's make ICSs work.
Great. A nice note to end on. Thank you very much for joining, and thank our panellists.
Sorry, we overran by a few minutes.